Hi, good afternoon, everybody. Welcome back to COVID-19 in Context. We're in week 5 of the course, and we're very excited to continue on with a lot of great talks this week and 3 more weeks after this. Students, let me just remind you that you do have a final paper that you need to write, and I plan to be sending you some details on that probably towards the end of this week, so you can start thinking about that final assignment. You'll have several weeks to complete it, but I'll try to get some details out to you soon. We're very excited to welcome our guests today from the Department of Geography, mostly, who are going to give us the presentation first. And we have another guest joining us a little later for the Q&A. Before we get to them, let me just thank all of you that responded to the survey that I sent last week. The response has been tremendous. Over 600 people have responded to my survey, and the feedback is generally very, very positive. So I'm really happy to hear that you're all enjoying this and getting a lot out of this course. So without any further ado, let's turn it over to our speakers for tonight. We have 2 of our faculty from the Department of Geography. The title of their presentation is Mapping and Analyzing the Spread and Intervention of COVID-19 over Space and Time. And with us are Professors Dawn Bowen and Professor Ping Yin from the Department of Geography. I'm going to turn it over to Dr. Bowen.
Thank you, Keith. So Ping, you ready to share your screen? All right, awesome. Technology is working. So hello, everyone, and welcome to today's presentation, where we're going to take a look at the geographic context for COVID-19. So to share our outline, we have 4 sections that Dr. Yin and I will be sharing. So we'll be going back and forth and talking a little bit about this. Geographers examine phenomenon over space and over time. It's what we do. So I want to begin with this word cloud, which indicates some of the key dimensions for what it is that geographers study. We consider where people live, how goods are distributed, how natural disasters might impact infrastructure, and yes, how disease spreads. We want to understand the location of an outbreak and what the implications, social, economic, political, among many others, are for the emergence of a new disease. Geographers examine differences and similarities from place to place, and we look at these at different scales. So we begin perhaps at the global scale, working our way down to the national scale, and then finally to a local scale, even the neighborhood level. So one of the foundational ideas of geography is movement. So over the course of millennia, the world has both expanded as new parts of the world have become known to other parts, and the globe has also shrunk as modern transportation makes it possible for people, goods to move thousands of miles in a very, very short period of time. Borders have become less significant as we have created an international marketplace. And certainly, while the movement of people and goods across the world seems pretty innocuous, when an invasive species, a pest, or as we are now well aware, a virus emerges and they become hitchhikers on these well-worn paths across countries and continents, the results can be devastating. When people move, so does disease. Other speakers have discussed the emergence of COVID-19 and its initial jump from other species to humans. As we are now well aware, once a virus enters the human body, it can be a very short period of time before that infection is carried around the world. I now want to turn over to my colleague, Dr. Yin, for an overview of GIS.
So thank Dr. Bowen for introducing the discipline of geography and its relations with public health. Now I want to talk about Geographic Information Systems, or GIS, the tool that is rooted in geography and has been widely used in different fields, including public health. So every second, there are tons of location-based data created in our world, such as our daily activity locations recorded by smartphones or GPS trackers, various maps made by amateurs and professionals, thousands of images taken by the sensors aboard on satellites and planes, and all kinds of tabular data, including location coordinates or street addresses. GIS are computer systems used to collect, manage, analyze, and visualize such location-based data. The most popular application of GIS is making maps, such as Google Maps. However, GIS functions can go far beyond maps. For example, we can use GIS to identify spatial pattern of disease spread, explore the relationship between risk factors and health outcomes, and optimally locate resources to fight diseases. The figure on the left shows the conceptual framework of GIS. There are basically three steps in GIS applications. First, real-world data will be classified into different layers based on their themes. For example, we can have a state boundary layer with the population and health outcome information, or a street layer showing the connections among cities. The second step will be linking these layers based on the locations. Finally, we will visualize, query, and analyze these layers together to produce new information or hypotheses. Before the invention of GIS, location-based analysis or spatial analysis has been used in different areas. There is a famous story in the history using spatial analysis for public health concerns. So in 1854, there was a cholera outbreak in Soho area of London. At that time, no one knew that cholera can spread through polluted water. Some people even believed that this disease was due to vapors coming from a cemetery of plague victims. To understand the reason of the disease spread, Dr. John Snow made a map showing the locations of both the cholera deaths and the water pumps in the area. The map showed that the deaths were not confined to the area around the cemetery. And most importantly, he found that the number of deaths decreased as moving away from the pump on the Broad Street. So it's highlighted here. So based on this observation, Dr. Snow assumed that the pump on the Broad Street was the problem and asked to shut it down. 1 week later, the reduced number of new cholera deaths proved that his hypothesis was correct. So this story perfectly shows the power of spatial analysis, which is an essential function of modern GIS. So after the brief introduction to geography and GIS, I would like Dr. Bowen show some health outcome maps of COVID-19 made with GIS.
Ping. So this first map that I want to share with you today is from the Johns Hopkins Coronavirus Research Center. It's probably pretty familiar to you. It shows total confirmed cases of COVID-19 globally. The map uses proportional circles to show proportional circles, so the size of the circle represents a larger number of cases. And if we look at the distribution of circles on this map, some data we have only at the national level. So if you take a look at Africa, for example, those countries are reporting at the national level. Whereas if you take a look at the United States, our data is reported at the county level. One thing that this map makes clear is that, unfortunately, the United States leads the world in the number of COVID-19 cases, with the greatest number of these reported cases. The next map shows cases in the US at the county level. This type of map is called a choropleth map, which uses differences in color or shading to indicate averages within a specific geographic area. The picture that it shows, however, can be misleading, and I just want to show two examples for that. So the dark red shading, as the legend shows, is COVID cases, confirmed cases more than 322. But if we look at Queens, one of the boroughs in New York, Queens has over 64,000 cases, while the city of Richmond, which has the same dark red shading, has 2,100 cases. Now, it is certainly true that both Queens and Richmond are well over 322 cases, but the differences between these two locations is very, very significant. So the question, how much has the virus spread? We do not know that from this map. And at the start of the pandemic, all maps showed cases as a total number. But a better way to understand the virus would be examining data that is adjusted for population. We know that people are not uniformly spread across space. Rather, they're concentrated in cities, large and small. And in some areas, there just aren't very many people at all. And so we see these large areas. Okay, so, sorry here. This map shows total reported cases by county. It also is a proportional circle map, and it is showing the total number of cases. The larger the circle, the higher the number of cases. It clearly shows that the greatest number of cases are in large cities, so New York, Chicago, Los Angeles, and increasingly Miami. But 2 examples again, Montana, 919 cases in the entire state of Montana, where Florida has just crossed over 146,000 cases. This map shows total reported cases per 100,000 residents by county. So again, we have adjusted for population here. It provides this quite different perspective on COVID-19 in the United States. So representing data in this way allows us to see a little bit more, with a little bit more clarity, where COVID cases are. For example, the population of Texas is 29 million people. Nevada is 1/10 of that population size. So the proportional representation provides a more accurate understanding of where COVID cases exist and clearly demonstrates that they are in fact widespread. We can show data at different scales and also over time. So this map demonstrates percentage change in the number of cases over a 1-week period. So you see that period is from June 9th to June 16th. 22 states had an increase over that period of time, but pay attention to the scale. The light brown shade indicates an increase of 10 to 49% in the number of new cases, the average number of new cases, whereas the dark brown indicates increases of 50% or more. These are very large ranges. Another example, if we look at the neighboring states of California and Nevada, what we see is that they are both shaded this light brown color, but in that period of time from June 19th to June 16th, California saw an increase in the average number of new cases of 10%, while Nevada's increase was 36%. So a map that shows what is happening in the United States at the state level fails to provide, again, that complete picture. Instead, if we examined county level data, we can get a better sense of the incidence of COVID-19. The final map that I want to share with you this afternoon also shows percent change in the number of COVID cases over a 14-day period. Most often, the data is represented at the county level, but as we move to the western half of the country, portions of counties that have fewer than 10 people per square mile are not shaded, again, to help the accuracy here. Large swaths of the United States, where few people reside, have few or no cases, as indicated by the gray coloring. There are also a sizable number of counties where the number of new cases, the increase is falling, so as shown in blue, or remaining about the same as shown in yellow. But there are an even greater number of counties shaded in oranges and reds where new COVID infections are rising. So how might different audiences respond to these maps, and how might they be used to help different actors respond to this COVID crisis? Maps which show data at the national or the state level are most useful for a general audience. People can see the big picture of what's happening. But more detailed maps, such as this one here, can provide critical insight to, for example, where more attention needs to be focused as we continue to address this health crisis. We can, for example, understand where we need to stage resources, where resources already exist, where prevention messaging might be enhanced, and finally, where restrictions on movement might need to be reinforced once again.
So as Dr. Bowen mentioned, so maps can be efficient to deliver all kinds of information and facilitate the communications. However, we need to understand that maps are just one representation of data. In other words, using different mapping techniques, where one data set can have different maps, leading to different interpretations. For example, color plate maps are very popular in disease mapping, like this worldwide COVID-19 incidence rate map shown on the left. However, they are also very misleading. First, the polygon size is proportional to the land area, and the larger polygons will get a great visual emphasis, making those small but populated areas be easily overlooked, such as some European countries. To address this issue, we can make cartograms that distort the polygons so that sizes represent an attribute of interest instead of land area. In this cartogram example on the right, the country polygon size is proportional to its population, and the color represents the COVID-19 incidence rate. From this map, we can easily identify the countries with both a large population and a high disease rate. The other issue with the color plate maps is the impact of data classification methods on the map's appearance. Data classification method determines which polygons should be grouped together and assigned with the same color. Here, 3 color plate maps show the COVID-19 incidence rate by state for the continental US. All are made using the same dataset, but different data classification methods. You can easily tell the differences in their appearances. Depending on which map they are reading, people could have different understandings on the geographic distribution of the disease. To get a better understanding, I suggest paying more attention to the map legend, so usually shown on the corner of the map, so which shows the range of each data group. So after showing several COVID-19 maps, here I would like to showcase how GIS uses maps and models to support interventions for COVID-19. Three aspects will be introduced. First is government policies. Since the outbreak of COVID-19, we have seen that government responses varied by country and over the time. To enable the comparison of government responses, the Oxford University developed a COVID-19 government response tracker where 17 response indicators have been measured for each country over the time. These indicators show different aspects of COVID-19 government policies and are further combined into several composite indexes. For example, stringency index consists of all of the indicators of containment and closure, as well as the indicator of public information campaign, showing how strict a country's policies are on the control of human mobility and interactions. This map animation shows how COVID-19 government response stringency index changes over the space and the time. The darker the blue, the stricter the policies. From these animated maps, we can see that China and some European countries started to respond to the disease from the end of January to February, followed by the rest of the world in March. The strictest responses across all countries occurred in early April. Since May, many countries in Africa and Europe started to lift confinement restrictions. Following the Oxford idea and methodology, the George Mason University developed the COVID-19 Policy Stringency Index for all the states in US. This map animation shows how strict the state governments responded to the pandemic in US from March to June. We can see that West Virginia, Maryland, and New Jersey took actions relatively early before the WHO announced the COVID-19 outbreak as pandemic on March 11. Some states responded relatively late, but took very strict policies at the beginning, such as New York. These charts compare the policy stringency index and the COVID-19 incidence rate over the time for 6 states. Their relationships are not conclusive. For example, even if New York, like this one, has taken very strict policies, the incidence rate was not controlled well before early June. There could be many confounding factors needing a further investigation. Monitoring people's mobility is important to understand how well people comply with the confinement restrictions and to identify close contacts of COVID-19 patients. Traditionally, we use an in-depth interview of patients to identify the close contacts. Nowadays, modern technologies, especially mobile devices and location-based apps, provide potentially valuable location-based data to infer large-scale human mobility and social interactions. Here, I want to show 2 examples using mobile phone data for human mobility monitoring and contact tracing. The first example is using mobile phone data to monitor the number of stay-at-home people. The bar chart shows the daily situation of Virginia from February to June, and the time series map shows several snapshots of Virginia counties during this time period. The value of 0, represented by almost white color, represents no change from the period before the outbreak. Yellow means more than usual people going out, while blue means more than usual people staying at home. On March 14, one day after President Trump declared a national emergency, all counties still showed a normal situation. On March 31st, one day after Governor Northam issued a statewide stay-at-home order, most counties saw a significant increase of stay-at-home people, especially those populated counties. On May 16, one day after Virginia's first phase of reopening, many underpopulated counties showed a significant decrease of stay-at-home people. On June 8th, 4 days before the second phase of reopening, many counties on the southern and western border showed that the number of stay-at-home people was already back to normal. The other example using mobile phone data for COVID-19 risk control is the adoption of a health status code in several countries. In China, more than 300 cities have requested residents to submit personal information and collected their location information through mobile phone apps. By linking these pieces of information with the COVID-19 health data and using some artificial intelligence algorithms, a real-time health status QR code is generated for each person, indicating 3 levels of risk that person may currently have. When people visit public areas, such as taking public transportation or entering office buildings, they must show their health status code and make sure they are in green color. Yellow and red colors mean 7-day or 14-day quarantine needed, respectively. Although individuals' location information could help fight COVID-19, there is a big concern with geoprivacy because the location data may be used to reveal such things as people's social, sexual, religious, and political associations. Compared to the US and European countries, people from some countries, such as China and South Korea, are more willing to share personal information for health benefits. How to use personal information to fight COVID-19 while preserving people's geoprivacy? On the one hand, we need to regulate the development of contact tracing apps through legislation and regulations, such as this guideline shown here, developed by the American Civil Liberties Union. On the other hand, we need to consider using technologies to avoid privacy abuse. There are several contact tracing initiatives underway. They try to keep the sensitive data on personal devices without exposing people's location histories. The last aspect of the intervention for COVID-19 in my presentation is the distribution of resources. As we know, accurate and large-scale testing is critical to control spread of COVID-19. There are several online maps and apps showing the locations and attributes of these testing sites. The screenshot here shows one example. I want to talk about this application because it reflects an important component in the modern GIS, volunteered geographic information. In addition to the testing site information directly coming from governments and healthcare providers, much information in this app is submitted by volunteers based on their local knowledge or the information from the internet. Since the outbreak of COVID-19, hospitals have experienced high pressure on the lack of resources, such as beds or ICUs. GIS can be integrated with the epidemiological models to predict and visualize hospital burden in the near future. The example here shows a model tool developed by a GIS company that takes different input data to predict when the peak of hospital resource use will occur. It is very useful to understand the impact of different policies on hospital availability and support resource allocation. In addition to mapping and visualization, GIS can use spatial analysis to help locate COVID-19 facilities, such as sites for testing, treatment, and food distribution. For these purposes, GIS first estimates the population demand based on multiple risk factors. Then, by running location allocation models, GIS can help identify the optimal locations for these facilities to maximize the benefits of the society. In the last part of our presentation, we will use 2 examples to visualize the impact of COVID-19. First, Dr. Bowen will talk about the impact on population groups.
Hey, I chose this map of Chicago. It's not the absolute best quality, but unfortunately, these kinds of publicly available maps are quite limited at this point. So, racial disparities, a topic that we're hearing much more about, but this is a tremendously significant visualization of what is actually happening. So understanding the disproportionate impact of COVID-19 on racial minorities is something that we're just beginning to understand and starting to address. So the three maps on the screen here, the map on the left is showing the proportion of African-American population in Chicago. So the greatest concentration of African-American population is in the southern half of the city. The map in the center is the number of COVID-19 cases, and you can quite clearly see that the largest number of cases is also concentrated in the southern half of the city where the African American population is greatest. And then finally, the map on the right, deaths from COVID-19. Again, largest concentration, greatest number of deaths in the southern half of the city, and then the largest proportion of people where we know data is that these are African Americans. So what we see here very clearly by looking at these three different maps, three different scales, three different pieces of information, the disproportionate impact that COVID-19 is having on African Americans in Chicago. In Chicago, African Americans make up 29% of the population, but in terms of the COVID-19 cases, they are 37% of that population, and a staggering 70% of the deaths. So the question is, why are Black Chicagoans being so disproportionately impacted by COVID-19? Why are they being infected? Why are they dying in such large numbers? So we've heard a great deal about comorbidities. That's probably a word nobody ever expected to learn, but we all know what it is now. So comorbidities, these underlying health conditions such as diabetes, obesity, heart disease, asthma, which increase the severity of COVID-19 infection. These comorbidities are often tied to poverty. They are tied to racial inequality. They are tied to limited access to medical care. Thus, a person's socioeconomic status and racial inequality play an outsized role in a person's level of risk. Other factors that are at play here related to poverty, where we see concentrations of poverty, people are often living in overcrowded conditions. If you have a family living in an overcrowded home, it's simply not possible to maintain distance from one another. Without that social distance, we know that the disease is going to spread. Another factor directly tied to one's economic status, evidence has shown that fully 80% of African Americans in the United States hold jobs which do not permit them to work at home. And so if you cannot stay at home, you are further confronted with the possibility of actually catching this virus. So again, I want to use Q&A and then discussion to discuss this more fully. But Dr. Yin will now consider some of the economic impacts of COVID.
Okay. So there are multiple ways to measure the economic impact of COVID-19. And I believe there are more topics in the future we'll talk about economic impact. Here, I just want to show the foot traffic or total visits to business based on mobile phone data. The map in the middle shows a snapshot of the foot traffic to all business by state. The value of 1, so the blue, okay, this blue color, so means the Euro foot traffic before the outbreak. We can see that on June 19, some underpopulated states with the darkest colors, such as Wyoming and South Dakota, had a foot traffic already close to normal, while some populated states with the lightest colors, such as New York and California, still had a foot traffic far less than normal. The line charts on the right show the foot traffic by business type over the time. The biggest impact has been seen in restaurants and movie theaters, as well as hotels. And supermarkets and general merchandise stores had much less impact on their foot traffic. Okay, so our presentation will end here. We want to thank you again for watching it, and we hope our presentation can help you understand how geography and the GIS can help fight COVID-19. Any questions or comments are welcome.
Great. Well, thank you so much to the presenters. Really a terrific presentation, and really enjoyed hearing so many different ways that geography can provide us with ways to interpret what's going on with COVID, not just in terms of number of cases and careful analysis about how that can be portrayed, but also in terms of compliance, and a lot of great questions that we'll get to in just a moment. I'd like to introduce another panelist for the Q&A. It's Professor Leo Lee, who's a professor in mathematics. He was working with Dr. Donald Stern from the Virginia Department of Health at the start of the pandemic to help model the spread using mathematics. And so Dr. Lee, thank you for joining us. I have the first question, and let me pose this to it says to all panelists, and I think I'll add a little bit to it, because as you can see in the Q&A, there's a question about what has been reported as an upsurge in cases recently across the United States. And the questioner is asking, do you think this could potentially result in another lockdown, or at least additional reinforcements of safety guidelines, recognizing that you're not necessarily coming from a public policy background, but to look at it in terms of how this is being mapped. Let me ask it this way. Given that there has been an upsurge in cases across the country, for policymakers to make a determination about what to do next, how should they use some of the mapping techniques and the technologies that you've outlined to make that decision? Should it be about the number of cases? Should it be about where the cases are? Should it be about compliance for existing safety standards? Or is it some combination of them? So I open that up. Let me turn it to Dr. Yin first.
Okay, so in my opinion, so I think the policy should be changing all the time based on the current situation. And of course, the mapping, I think especially the modeling, can help us to predict what could be possible, like what the situation will be in the near future. So that is very informative for us to make for the policymakers to make the decision. So for example, like I would like to take the example of Beijing. So Beijing actually, so I think in last month, there's almost no new cases. So they lifted a lot of confinement restrictions. But after several days, so a bunch of new cases emerged. So the government take another measurement. So they try to confine the movement of the people. But I would say, so we need more targeted policies. So not to inject like just one solution. So we need more details, like which is area with the highest risk. So we can take different measurements for based on the situation of different places. So that will also can minimize the impact of the COVID-19 on our economy. So that is just my opinion. Yes.
Thank you. Thanks for that. So the next question was in all likelihood submitted by a student, and I think it touches on an issue that many of us have on our minds, and that's the return of the students and the faculty and the staff to campus in the fall. And I'm wondering, maybe Dr. Bowen, could you comment a little bit on how an understanding of the geography of our campus could help us to mitigate risk in the fall?
We've learned a lot already. What we as a country have not done well is putting what we've learned into practice. So I think, you know, as we've had these discussions on campus over the last several weeks, we know that we are reducing the amount of contact that people will have with one another. We're reducing the number of people who can go into a particular space at any given time. There'll be restrictions on presumably directional flows in stairwells and that sort of thing. Those are parts of the issue that we need to address. Obviously, wearing face masks are, you know, also going to be critical. The reality, unfortunately, is that until there is a vaccine, nothing is 100% guaranteed. So, you know, people have to be cautious. They have to be mindful. They have to wear a mask. And that's, you know, one of those issues that has sadly become politicized. But I'm glad that we're saying you have to wear a mask if you're going to be on campus.
That's excellent. Certainly a lot for us to consider as we're thinking about coming back to campus and mapping our own actions. There are a couple of really great questions, and luckily they were both near the top, but I want to combine these two because this is something that was touched on in the presentation. And I want to direct this to Dr. Yin to start with, and Dr. Bowen, you're welcome to jump in as well. But these have to do with manipulations or misrepresentations coming through mapping and the way that data can be misunderstood, misrepresented, or manipulated. And so the questions ask both, what should we be looking for to be able to detect that manipulation or misrepresentation? And is it possible that these maps have been manipulated in such a way that it's manipulated the public's view of the pandemic? So it's not just a manipulation of the view of the initial data, but maybe the broader understanding of what's going on.
Yes, as I mentioned in my presentation, so like maps, just one representation of data. So data could be represented in different ways. So we can use just like a table, right? Like a spreadsheet. We can use like a charts, right? Like a statistical charts. So different, but all of these representation just show one aspect of the data. So if you, the only source you can get is one map, I think that is impossible to get a full picture of the situation, because that map could be always manipulated using different mapping techniques. As I mentioned earlier, it's like a data classification methods. So there's a famous book in cartography called Maps Can Lie, right? How to lie with maps. So that follows the book from statistics, how statistics can lie. So this is, so that is very difficult. So if you only have one source of the data, like that is, but I would say, so for, as much as possible, so if you want to know more comprehensive data, like a situation, it's the best way is to try to get the resources from different places, try to get more data sources. The best thing is a way, maybe just to look at the raw data. So now the reputation is easier to have people communicate, to understand the initial idea of how the situation, but the best thing is to look at the raw data. But I would say, so this is sometimes public have no access to those data, and also sometimes people don't have this technology or knowledge to understand, to try to understand the data. So that's the education trainings are also needed. So this is, I would say, so yes, so maps can always be manipulated. So how to, yeah, so mitigate this issue. So one thing, you need to learn some like cartographic knowledge, right? How the maps are made, what the principles followed to make these maps. So that can help you understand what uncertainty, what could be hidden behind the maps. But you may not know the fact, but you know, okay, that could be manipulated. That could be the false, like positive information, such as that. But I would say the best way is try to get the resources of the information as much as possible.
I would
All
say,
right. Sorry, go ahead, Dr. Bowen. Sure.
I would just add to that quickly that I'm not fearful that the data was manipulated. It's simply how it's being represented. So I discussed the various, the various scales that we need to be aware of. So if we look at, a national map versus a state level map versus a county level map, we actually see three very different things. So it's how we interpret the map.
Right, right. Makes a lot of sense. I'd like to turn to Dr. Lee for a moment, if I could. We had a question about modeling the spread of the disease, and when you're looking at the spread and trying to understand, what's going to happen, a week down the road, a month down the road. What kind of inputs do you look at? Do you just look at total numbers of cases? Do you look at deaths, or what sort of data do you look at to try to build an accurate model to predict what's going to happen down the road?
All right. Probably it's better to just tell you what I did with Dr. Stern. I was given the two sets of the numbers. And one was the set of the numbers of new COVID-19 cases. So that means I was given just numbers. And then the other one was the set of the numbers of new hospitalizations. And then I used the regression analysis and the method of risk scores to find the future numbers. So that means just numbers, and then use those numbers with some method, I find the future numbers. In case you're wondering about the regression analysis, it is the statistical tool, and that tells us the relationships between independent and dependent variables. And also it does use the method of risk scores. And the method of risk scores, as you may see from the name of the method, it is for finding the best fit function for the data set by minimizing the scores. For example, let's say you have a point given that is from the director of the health department, and then we have anticipated point, which is from the function I'm looking for. Then you have a gap between these two. What I'm doing is to try to minimize this gap so that you can use this for anticipating that point. And then you do consider another set of the point. For example, you have the point given from the, again, director of the health department, and then you have point over here, which is anticipated point from using the function. And then you still have a gap between these two. And here, this gap is positive if you consider this point given from the Department of Health minus anticipated point. That is positive because this point is above that point. And then if you consider this set, then this is negative simply because given point is below the anticipated point. Then the sum of them is equal to, it might be 0. If say this is 5 and this is -5, then sum of them is equal to 0. But 0 means actually no gap. That is not true, right? So you have gap here, you have still gap here, so that cannot be 0. Why that happens? Because we are using positive and negative numbers. So what I did is to use squares. So that means this one squared and then that one squared. Then some of them is positive, of course, and then use the calculus. What I mean is, as you can see from the, again, name of the method, the risk scores method, I try to minimize the scores. In there, I use the calculus. That means differentiate the sum of the scores and then find the derivative and then set that equals 0 and then find the critical numbers. And then once you find the critical numbers and use those numbers with boundary data to find the some unknowns of a function. That is the modeling function. And then I use that modeling function with the future date to estimate future numbers such as new COVID-19 cases and new hospitalizations. If you run more about those kind of techniques, then actually you can run more about those from taking Mathematics 115, Introduction to Mathematical Modeling, and then Mathematics 121, which is calculus. So from 115, you will learn about regression analysis, and from 121, you will learn about optimization by getting general education credit, and you have a skill to help out our community as I did. So numbers given, and then find the numbers from that. That's it.
Sounds like a little bit of an advertisement for our students there, Dr. Rao.
Yeah, I'm representing Math Department.
That's excellent. Thank you, Dr. Lee, for that. The next question that we have is asking about how geography factors into the spread of COVID. You know, certainly we can look at factors such as social distancing, mask wearing, public policy decisions. Turning to Dr. Bowen, do you have any examples where the geography, the geographic makeup of a country or region has been a factor in how coronavirus has spread or maybe not spread as rapidly as others?
Sure. So thinking back to my presentation, I mentioned Montana. So Montana is enormous, has a relatively small number of people living there, and fewer than 1,000 cases of COVID-19 statewide. So there are many, many counties, especially in the eastern part of the state, where almost no one lives, where there simply are no COVID cases at all. Social distance in some ways is a way of life. You know, people go into town once a week, maybe once every 2 weeks. For that very reason, without that initial carrier of the virus, it simply didn't have the opportunity to spread. So where we see cases of COVID in Montana, for example, are in the couple of larger cities. See a little bit of tracking along the interstate system, not quite sure why that might be the case, but far more number of cases in the western part of the state, which is more densely populated.
Thanks for that. I'd like to turn to Dr. Yin here. This is a question that's coming from one of your colleagues, and so I think the pressure's on maybe. I want to get your thoughts on the strengths and weaknesses of policies. So things like mask wearing or shelter in place or social distancing, any of the policies that we've heard about at the local or state or national level. What are the strengths and weaknesses of looking at those different kinds of policies at different levels?
Okay, so everything has two sides actually. So these policies try to prevent the spread of the disease further. So especially the social distancing and wearing the masks. So they have been proved very effective in different countries already. So, but of course, on the other side, so these policies, so first, so they limit the people's human mobility, right? So people cannot go to work, students cannot go to school to get education. So there are definitely adverse impact on this situation. So I would say, as I mentioned earlier, when I answered the first question, so policies so always have different impacts, positive and negative, but we need more like targeted policies. So try to limit the impact of of area. For example, so if we cannot use the same policy for the whole country, right? Sometimes, not currently, so in US, most of the policies are made by governments of the state at the state level, and of course the federal, the CDC give the guidelines. But I would say so even within the state. So we still need to refine the policy. So try to understand which specific area, what kind of a population have the highest risk. Based on the geographic distribution of these high-risk populations, we apply different levels of policy, try to maximize the benefit and at the same time, so try to minimize the adverse impact. So that is my idea. So
that's very good. Thank you. I'm sure your colleague will find that a satisfactory. Appreciate it. The next question I think is a good one for Dr. Bowen, and it's talking about human geography, cultural geography, and maybe thinking about this more internationally. How big of a role would a collectivist or individualist cultural difference play into the spread of coronavirus and in the application of public policy? Do you see any examples where a more collectivist culture is one that handled coronavirus and was able to implement public policy better or worse than an individualist society?
sadly, there are a number of good examples where countries have simply handled this better. New Zealand is probably the best example where, you know, the message was, we are, you know, as we say here, we are all in this together, but it was taken much more seriously. There was a very significant lockdown. People stayed in place, and the number of cases basically came down to virtually nothing. They have risen again, but that is because some New Zealanders have been returning, and they're bringing the disease back with them. If you contrast that with the United States and even individual states where, you know, again, we hear this routinely, that it's a violation of my civil liberties. You can't tell me that I have to stay at home. You can't tell me that I have to wear a mask. So, you know, quite simply, those populations who have been more willing to accept some limitations for a period of time have handled the pandemic far better than we have in the US.
Thank you. Dr. Bowen, Dr. Yin, thank you both so much for the presentation. This was really fascinating. This is a very important part of this course that we heard today, that we hadn't heard much about this sort of thing until now. So this was really terrific. I appreciate it very much. I'd like to turn our attention now, if we could, to our last guest that we have today. I'd like to introduce Miss Allison Balmes-John, who works for the Virginia Department of Health. She's a population health coordinator and the COVID-19 public information officer for our regional section of the Virginia Department of Health. And she's going to give us a briefing here for a few minutes. And I would like to allow a little bit of time if there are some questions that folks have for her. We can certainly do that. I'd appreciate if you would go into the chat box and type 4VDH maybe first, so we can make sure that this is a question that you'd like to direct to Ms. Balmes-John. So we'll give her a few minutes here to speak, and then we'll try to have a short Q&A as well. So thanks so much for being here, and let me turn it over to you for a few minutes.
Great, thank you. Hopefully everybody can hear me. I'm going to attempt to share my screen here. And if it does not work, we will be okay. All right, I'm hoping that's working. Dr. Mellinger, I don't know if you're able to let me know.
Yes, we can see it. It's not in presentation mode, but we can see the slide.
How's that? All right, yep. Great. All right. Well, thank you, first of all, for giving us the opportunity to just kind of give a little bit of information about the role of the local health department during COVID-19. This is something that we've been hard at work on for many months now. So we really appreciate the opportunity. So I have been serving as the public information officer for the Rappahannock Area Health District, which is the local health district in and around Fredericksburg. So we actually serve 5 localities, Fredericksburg, Caroline, King George, Spotsylvania, and Stafford counties. Here in Virginia, we have what's known as a centralized public health system. So the local health departments are also part of the state health department. And our specific health district serves a population of over 360,000 people. So we are one of the larger districts within the state. We do run all of the health departments within this area. So in addition to COVID-19 response, we're still offering clinical services, we're still doing restaurant inspections and a lot of different activities. But I will be focusing today on what we've been doing with COVID. So first, just a little bit of background. I can see from today's presentation that you have already learned some about what the field of public health is. This is something I could literally talk about for an hour, and I've got about 5 to 10 minutes for this presentation. But public health is seeking to protect the health of entire populations. So we're looking at the whole community, not just one individual when we're looking at protecting health. And a lot of what we do is really focusing on preventing health problems. So this can be done through a variety of ways. We can use programs, we can use policies, we can use services, we can do research that's going to, in the end, be able to help the health of a population. We are not the same as health care, and this is a common misconception, I think. So in contrast to clinical professionals like doctors and nurses, they focus more on treatment, but we're focusing more on the prevention before people are becoming sick or injured. And so you can see with COVID-19, where we're dealing with a new virus, where there are not really a lot of treatments at this point in time, public health really plays a critical role in preventing the spread of disease. So there's two key roles I'll talk about that the health department has played during COVID-19, and that's prevention, and then also a piece on surveillance and data. So one of the first ways that we work to prevent the spread of COVID-19 is what we're calling boxing in the virus. And so this starts with testing. And I think everyone has gotten this notion that we, at least initially, we didn't have enough testing. We needed to know more about who actually had this virus. But I think that there's been a little bit of a disconnect of why we need to test. Because testing itself doesn't necessarily prevent. It just tells us who has the virus at that point in time so that they could ultimately get treatment, say, if they need it. But we want to test widely so that we can identify who has the disease and then isolate them. Once positive lab results for COVID-19 are received in this area, the health department is notified quickly, usually within 24 hours. Labs are required to report this disease. And then we will be following up with those individuals to conduct what's known as a case investigation. So this is the point where we're going to give them instructions on isolation, how long they need to do it, what symptoms they need to keep an eye out for. We're also going to gather information on who their close contacts were while they were infectious. Once we have that information, we reach out directly to those contacts to ask them to quarantine for 14 days. So as we're going through this process, we're really able to keep that disease contained because we are containing for a short period of time people who are infected. And then we're also kind of keeping those people who may be exposed, who may be developing the disease or most likely to develop the disease, keeping them away from others for a short time as well. During that quarantine phase, they're going to monitor for symptoms. If they start to develop symptoms, we're going to ask that they get tested right away. If they don't develop symptoms during the course of the 14 days that they're at home, then they're back into the community, kind of back to normal life. So that's one of the ways that we prevent the spread of COVID-19. The second way is really what I've been focusing on, which is communicating and educating the public to prevent the spread of disease. So I know for a fact that you all have heard all of these things. I put a few flyers from CDC and from VDH up here, but I think at this point we all know that we need to wear masks and we know that we need to socially distance and stay home if we're sick and frequently wash our hands. And I think some people are actually getting a little fatigued from hearing us repeatedly say this, but it shouldn't be minimized that when we're thinking about preventing a disease that we know is spread primarily through respiratory droplets, we want those droplets to stay contained. And so that's why wearing a mask can be really effective. That's why we want people to stay apart from one another so that they're not going to be inhaled by somebody else. So these simple steps we've seen over and over again can make a really significant difference in preventing the spread of that disease. And then the last piece I'll talk about that has been really important for the local health department during COVID-19 is just trying to address special populations and specific community needs that are out there. I know that over the course of this course, you have heard a lot about how all different people and fields and businesses and nonprofits and whatever it may be are impacted by COVID-19. This has been an unusual emergency because everyone is impacted and everybody's trying to figure out what this means for them. So I've listed what I could think of offhand as some of the organizations that I know that we've heard from during COVID-19. I'll talk about the first two just as examples. So nursing homes are someone we've had very close contact with in our area. We know that nursing homes house a lot of the people who are most at risk for really severe cases of COVID-19, often because they're older adults and because they're more likely to have some of these underlying medical conditions that can be more severe. They've also had some of the most kind of extreme restrictions go into place where there's no visitors going in, they're not doing communal dining anymore and that sort of thing. But even with some of those recommendations in place, we see that people are still kind of coming and going from a nursing home. Staff don't live at the nursing home, so they're still going home to their families. They're still going to the grocery store. Residents still might need medical care at the hospital. And so how do we, with all of these moving parts, take what we know about preventing the spread of disease and apply it to this specific setting? Schools have been a hot topic as well, as we're preparing for everyone to go back in August, and also with the guidance that's come out from the governor within the last couple of weeks here. And so once again, we're trying to work with this specific environment to apply the public health guidance and the research that's out there on this disease and kind of match those up so that we can prevent the spread of disease in that specific setting. It's interesting to think through, even with something like K-12 schools, if you're thinking about social distancing, say on a bus, that means that you're taking a school bus that could seat maybe 60 people, and now it can only seat about 10 to 12. Is that going to be feasible for the school to run? How can we kind of work through what we know to both allow people to go back to school and also put those, make sure everybody is staying safe and healthy? Also thinking through what happens if somebody becomes symptomatic during the school day or while they're on campus. How will we go through this method of kind of boxing something in that school setting? And so the last piece I'll talk about is data and surveillance. And so the field of public health, like a lot of other fields, is involved in data and cares a lot about data. And I think we really look at it in terms of monitoring because we want to understand what's happening in our community. We also want to be able to distribute that data so that it can be used by local governments to inform the decision making that they're doing. But we're also really heavily involved in the data collection process. So there's a couple screenshots on this slide that are taken from the VDH website. So those of you who may have been on there, these may look somewhat familiar. These are actually from today. But if you look on that one on the right, this has demographic data. And I think that what a lot of people don't realize is all this data that's going all the way up even to the CDC for things like age and race and gender, that's all starting at the local level during that case investigation process. And so we're asking folks these questions so that we can learn more about this disease and in turn make better decisions as we're moving forward. So lots of moving parts within the health department. I'm happy to answer more questions because I think that's kind of the tip of the iceberg, but I hope that's given a little bit of context about what kind of what's going on behind the scenes for us. I've listed our website as well as our call center number if you have any questions you want to talk through, and I'm happy to answer questions by email after today's session as well.
Thank you so much. We really appreciate you being here and for that informative presentation. And I know that we could spend probably hours going through so much of the informational work that's being done by the VDH. We do have a few minutes for some questions. And if you don't mind, I'll go ahead and start with the first one. Sure. Somebody asked about, given during the pandemic that a number of healthcare facilities have been closed to even immediate families, is there any indication as to when some of those facilities, such as nursing homes, will be open again for families to visit their loved ones?
Sure. So this is something that's come out within the last week or two. Just like the state of Virginia has had a phased reopening, there will also be a phased reopening for nursing homes. So as we're seeing that they're meeting certain milestones, such as not having any cases that are newly popping up within that facility, then they'll be able to advance. So if you're interested in more of what that looks like, that is available on the VDH website. It's a little in the nitty gritty to go through right now, but it will follow a similar phased reopening.
Excellent, thank you.
Thank you very much for that. Yeah, it's fascinating stuff. I know a lot of us have a lot of anxieties with our children heading back to the schools, and you touched on that a little bit. One of the other questions that was asked was about reporting in the schools, and you know that the bottom line is what constitutes informing individuals in close contact with positive cases. In the case, for example, when a classmate in a school classroom is positive, what constitutes informing individuals? Or do they need to tell all their classmates?
Sure, that's a good question and something we've been spending a lot of time working through. So when we're reaching out to close contacts, the definition that we're usually using for that is a close contact is anyone who's been within 6 feet for 15 minutes or more. So when we identify that a case was in a school, we'll go through our normal case investigation where we'll be talking with that child, probably their parent more likely, especially if they're a young child. Also maybe connecting with teacher or other staff to help identify who they were around while they were infectious that's going to meet that definition. But we're also encouraging schools to do a little bit of additional outreach to others, maybe others who were in the classroom who might not have been a close contact, but where we want them to be aware. We will also be encouraging that schools are doing a notification school-wide, just that this has taken place. This is not so much because of a high risk to others in the school necessarily, but we know that word travels fast, and we've seen throughout COVID-19 that there's a lot of fear and anxiety that's out there in the community about this, and we want people to know that in advance. One piece I will unfortunately add is that we do still have COVID-19 in our community, so for some of these schools, it's not so much a matter of if there's ever a case, but when there might be a case. And we're making sure those schools have those protocols in place in advance to control the spread of the disease.
It's important for us to keep in mind. And I think that's related to the next question, talking about as we move into phase 3, we are talking about moving into phase 3. And as we're moving in, we still have COVID in the area. We still have cases of coronavirus. How confident is the VDH, or how confident are you that we'll not see the same kind of rise in cases that Florida, Texas, Arizona, states like those have seen as they've moved into a similar phase?
Sure. I'd be lying if I said I wasn't a little nervous. Here in the Rappahannock Area Health District, our numbers are actually looking pretty good right now. We have seen lower numbers of new cases. We're seeing a really good positivity rate, which is the number of new cases over the total number of tests. And our hospitalization numbers are also looking pretty good. Obviously, this can change, as we've seen in other states, so it's something where we'll be continuing to monitor. The best advice I can give is to continue to follow the precautions like social distancing, like wearing a mask, and encourage those around you to do the same. I think that we're very social creatures and we kind of see what other people are doing. And so I think that's a really big part that we can all play as we move into phase 3.
Yeah, I think we have time for just one more quick question here, and it has to do with the wearing of masks. Okay. We've been talking about this, for 5 weeks, I think, in this course. But can I get your input a little bit? I mean, there are some folks who are still resistant to this. I was at Lowe's over the weekend, and I witnessed it firsthand. It's a mix on the use of masks. And how do you convince others that this is the right thing to do? Is it the right thing to do, and how do we convince others?
Sure. It's been surprisingly challenging. We all know that this has become a politicized issue, which I think is an extra challenge in all different aspects of COVID. To me, the important thing to remember is that you're not even wearing the cloth mask to protect yourself, you're wearing it to protect others. And so we know that there are people in our community that are really vulnerable to this disease and in fact at risk of death. And so to me, by wearing a cloth mask, yes, I get it, they're uncomfortable, especially when it's hot out, like you just want to air it out in there. But worst case scenario, you're uncomfortable for a few minutes, but best case scenario, you're saving somebody's life. And so finding ways that we can kind of talk ourselves through that and remember that we're looking out for those around us, be it our family members, friends, or strangers in the community. I think that for me personally, that's the most compelling reason to wear the mask.
Well, thank you so much, Ms. Allison Balmsdown, for joining us today and taking time for the presentation to answer questions. For all of the attendees, I put the VDH website in the chat box. and as she graciously offered to answer more questions later via email. Thank you for that, and please feel free to share. We have more questions, obviously, in the Q&A box we weren't able to get to today, but we'll be able to keep that dialogue going with the Department of Health, and we appreciate all the work that they're doing for public health and also the support of these discussions happening in the area. So thank you for that. Also, thanks again to the panelists tonight, Dr. Don Bowen, Dr. Ping Yin, and also Dr. Leo Lee for joining us for the discussion. Wonderful presentation. We have another equally exciting one coming up on Wednesday, and this is with some members of our Department of Modern Languages and Literatures on the topic, We're All in This Together, World Visual Cultures and COVID-19. And joining us will be Dr. Betsy Lewis, who is the Assistant Dean for the College of Arts and Sciences and Professor of Spanish, Dr. Marcel Rotter, Associate Professor of German and Chair of the Department of Modern Languages and Literatures, and also Dr. Brooke DeLauro, who will be joining us then for that discussion. So please join us again at 4 o'clock on Wednesday. Students, we'll see you in a few minutes in the small group discussions in the other Zoom meetings. Thanks and have a good night, everybody.